So although multidisciplinary care is much appreciated by the patient and the physicians alike, it's very time consuming. If you were to see 10 to 20 patients in a half day and you dedicated that half day to multidisciplinary, in essence, you'd probably be seeing 4 or 5 patients, maybe initially, maybe in the long term. Because what tends to happen is that not only do you see the patient, you see them with one of your colleagues or partners, the surgical colleague or the radiation colleague. You go back, you review the case, you come up with a plan, and then you come back and discuss that with the patient. In real community practice, that would be 2 visits. But in a multidisciplinary clinic, that's all encompassed in 1 visit. So it needs to be well structured to give you the time to take care of these patients on that particular day. And it also needs infrastructure in terms of scheduling. You're really tying in 2 busy or 3 busy physicians together in one spot to see the patient in that one room. And that needs good coordination from whether it's the front desk schedulers or your team, your medical assistants who are working and scheduling these things. So there's always a crosstalk and communication to make it smoother and better. And I think the main thing is time, as you would imagine, and the capability and infrastructure and support from the hospital or the institution you work at or the community center that you work at to be able to give you that support to carry this level of care. So patients of locally advanced gastric or GE junction cancer tend to be very sick with a multitude of symptoms. The most common symptoms that you need to address tend to be pain, nausea, vomiting, obstruction, and ascites. And what we try to strive at our institution is to have the pain and palliative team join us upfront when a patient is diagnosed with locally advanced or metastatic cancer. So they team up and work with us to address some of these symptoms and goals. And all along, there's a multidisciplinary approach because when patients have nausea, vomiting, or obstruction, you sometimes need a surgeon to create a gastrostomy or a tube to drain the obstruction or to result in a J tube or a feeding tube to help them with the nutritional needs. A nutritionist to help us in supporting the patient and the family and managing their nutritional needs at home. Occasionally, the tumors get obstructed and you can put in a stent, which is an endoluminal stent put in by the gastroenterologist, and that for a short span of time could also work. So the decision of whether you put in to palliate the symptoms of obstruction a J-tube or a stent depends on the prognosis of the patient, depends on the expertise at your institution. And all that comes into the pathway as to how you take the next steps with these patients. Other symptoms such as pain are addressed very well when you have a pain and palliative physician following the patient with you. The way we've devised it is that our pain and palliative physicians round with us in the morning when we do inpatient rounds. So they're well aware of some of the sicker patients that they're going to see. They set up appointments in the outpatient setting so that these patients can then be continued to be followed with them. We do have a coordinator in the office who actually her full job tends to be to coordinate these visits so that when the patient is seen by us in the medical oncology office, the palliative doctor knows to come in and see him. So the patient who's already sick in need of pain and palliative services does not have to go to another office. So that limits and improves the quality of life of some of these patients and limits the unnecessary visits and improves their quality of life significantly. At our institution, we've been fortunate to have a Medicare-initiated program called MCCM, and it's a Medicare choice program open in 180 centers, which is really akin to hospice care. And the difference being that we all know as treating physicians that when you have hospice care, you really can't give chemotherapy and radiation and actively take care of your patients. But what the MCCM has devised is that you would get your hospice services for your patients and the family, but you don't have to stop giving the active treatment because your goal is still symptom management, your goal is still palliation, but you do it alongside this team while giving chemotherapy, palliative radiation, supporting them, watching them through their office visits, but giving them that extra hospice nurse or care at home to improve their quality of life.